Hello and welcome to this month's episode of the Atrium. This month I'm joined by Dr. Randolph Chitwood and we're going to be discussing the future of minimally invasive cardiac surgery. So welcome everyone to this month's episode. We've got an amazing episode with an amazing guest, and when we come to talk about the topic of minimally invasive cardiac surgery, there is no one better that we can really have on. We'll be speaking to Dr. Randolph Chitwood, going over his career and how he got into this field of minimally invasive cardiac surgery. We'll give a bit of a background to minimally invasive cardiac surgery, what's going on at the moment, where we're going, and also this is a podcast for trainees, so any advice for trainees and how they can get involved and how they can pursue their careers. I thought I'd just start by giving a bit of overview, Dr. Chitwood, about your career. So you got your medical degree from the University of Virginia. You then went on to do your surgical training at Duke University Medical Center with Dr. David Sabiston. You trained in both general and cardiothoracic surgery, which is, normal there in the States. After that, you went on to develop and head a new cardiac surgery program at East Carolina University School of Medicine. You've spent most of your career there at East Carolina University School of Medicine, apart from a couple of years at the University of Kentucky. Then went on to pave the way for the development of the East Carolina Heart Institute, basically building a building from scratch and setting up this whole new institute. But aside from that amazing clinical career with all these thousands of operations that you've done, you were the principal investigator for the FDA robotic mitral valve trials that really brought their use of robotic mitral valves to the US. Aside from all this, you're a member of many societies. You're the past president of ISMICS, of SCTS. You've been the Edsel board of many different things, including CTSNet. And you've got over 200 peer-reviewed papers. It's an amazing career, but what brought you to medicine?
I come from a total doctor family. My father and my grandfather started practicing on a horse about 1912 up in the mountains. My uncle's a surgeon. My sister is a doctor. So we got a lot of doctors in the family. But I took a different route. I went to several job fairs there on campus, but there was a chemist who had trained at the University of Virginia from DuPont, a high-level executive who I liked a lot, and I liked what he was doing because it was science. And so I took the job, and we moved to Delaware, to Wilmington, Delaware, and I had steel-toed shoes and a suit and a company car. I thought I was really something. So basically, after that, I decided maybe I'd try medicine, but didn't think I could get in medical school. So I went down and talked to one of my old professors, and I would say, maybe I'll do this, maybe I'll get an MBA, maybe I'll do this. He says, "You're a doctor, son, you're a doctor, and don't forget it. I have a spot for you." So it sounded good to me, but this was a pivotal moment. I was leaving a very good job. So this is one of those definitive moments. You got to change your life if you're going to change it.
So I just think it's amazing that for someone who took a chance on medicine, just gave it a go to see what it was like, to then your first year after residency, build your own cardiac unit, take 2 nurses, build an ITU and do 300 cases in a summer. I think it's just really quite inspirational that, you put your mind to something, give something a chance, and you're determined, you can achieve lots. And what I really like and what I really admire about you is this bringing together teams. And it's something I'm quite passionate about, that we shouldn't be these separate departments. We should be working together for the benefit of our patients. And
that's right, Alice. In fact, we were very early on having a heart team.
But what was it that made you go for the minimally invasive? What was that? When was that first thought about we need to do this different?
When Andres Grunzig did the first angioplasty in 1977, I think. By the way, he presented it as a poster.
Yeah.
In the American Heart. That's the first minimally invasive procedure that was really done therapeutically. So I knew, and we're doing gallbladders. Now, I'd never seen a gallbladder taken out with an endoscope in my training because we weren't doing them. Mm. And so, I was seeing lots of things going GYN, minimally invasive, and GI surgery too. Mm. So I said, there's no reason we can't do this operation. Now, I knew how to repair mitral valves. I tell people I can't teach you everything at once. So we did this operation and we presented it at the AATS. So a little bit later, I can't remember which year, maybe 95, a young MBA got me at a meeting and said, Dr. Chitwood, I want you to come to California and see a robot that can do heart surgery. I said, get away, kid. No robot can do heart surgery. He says, please come. So I went out there and they had the prototype. They had bought the patents from Stanford Research Institute to form Intuitive Surgical. And they had a prototype there. And so I started working with this thing. And basically I said, it was a eureka moment. Like the first time I saw a CT scan at Queen Square in London. And I said, but this thing's terrible. It's clanky. The vision's not good. But I said, the concept is wonderful. Carpentier did the first one. He always liked to do the first one. The next week they moved to Leipzig and they called me and said, can you be in Leipzig next week? And I said, absolutely. So I was with Friedrich Moore,
Yeah.
and Voltmar Falk and all these young surgeons who are now chiefs, and did coronary surgery and mitral valves, 7 mitral valves, and they did fine. And so that was really the birth of robotic cardiac surgery. It wasn't FDA approved, so we went to the lab and we spent the next 9 months setting this up to do the mitral operation and, operating cadavers, animals, all kinds of stuff. Then we took it back and we went to the FDA during this time.
Yeah.
And got approval to do a safety and efficacy study. And that was the beginning. In 2000, that was the first case in May of 2000 with the machine. That was under FDA. And then we did 30 cases without any bad consequences. And then we got a multi-center trial that we ran around the United States with 10 different centers.
And why the mitral valve? Was it just because that was what you were used to? Or do you think, the mitral valve has obviously become this flagship of robotics. Why do you think that is?
I took advice from Dr. Poise, who was the new chairman when I started the program. He says, pick one thing that you really like to do and pick something that no one wants to do. And you'll always be busy.
And why do you think it was, when you first brought this minimally invasive, or the robotic especially, why do you think it was met with such, people weren't interested and thought it was going to fail? Because it seems like a stepwise progression. We've taken a large incision, we've made it smaller and still direct vision, we've used cameras, and now the robot just seems the next step on that progression. Why do you think people were so against it?
If they have a proven operation that they can say thousands of patients have been operated on with, less than 2% at that time, 1% mortality, and very few complications, why should we step out and try to do something and maybe have a complication or problem that would shut us down? So surgeons don't like to change. But I think it was the robot that really told me that I could get excellent vision and I could reach all parts of the left atrium.
How should we be training people now? Because obviously the robot's the standard of care, but should trainees be going and residents be going directly onto the robot, or do you need to perfect it open or endoscopic direct? How should our training look now?
I think first off, we can measure metrics now, put them on a simulator, and there's some basic metrics. And most of the people, young folks, who finish their residency, they're very dexterous and they've done all kinds of general surgery with scopes and thoracic surgery with scopes. And so, they learn very fast. And we would grade them on speed, accuracy, and ergonomics. We start them out with some training. They don't have to step out of the program to do that. I mean, they basically can do it in spare time. What I always say, you got to learn to do a mitral valve repair the old way through a sternum. Then you've got to be able to feel confident with the machine in an animal lab or cadaver lab. And then, I will bring you up how to repair this valve piece by piece by piece. So now that you can repair a simple mitral valve.
So it's about getting that whole team involved and, making it a culture in your hospital.
The people who fail, they either don't know how to do a mitral valve repair, or they know how to do a simple one, they take on a complex one, or they don't have support from their administration, the head nurse in the operating room, taking care of the robotic stuff, and have somebody to work with the robot to keep it tuned up, so to speak. It's a team sport.
So I thought I'd give a bit of a background to where the minimally invasive came from. And there's actually quite a nice quote from, is it Catherine Moore from MD, an MD from Intuitive Surgical, who said, "A surgical incision provides no therapeutic benefit." And I quite like that as a, I've never thought about that. And I quite like the fact that we need, this is where we've come with minimally invasive, is that we need to get better because it has no purpose. But we were always sort of, you're always taught that a bigger exposure is better. And actually with minimally invasive, we've proved that that's not the case. We do think of minimally invasive as this new revolution and this new modern thing. But actually, if you go back, when Kolosov did the first bypass of a lemur to the LAD, that was through a thoracotomy. So, we've actually been doing these minimally invasive. We almost went backwards for a while when we did the full stenotomy. And just for maybe our more junior listeners, when we talk about minimally invasive, we're covering quite a broad spectrum of types of operations. So this can include mini stenotomies or hemi-stenotomies, endoscopic, and robotics. And it's kind of, that's how it's progressed. It's gone from these small incisions with direct vision to endoscopic to robotics. And now actually we can replace valves, we can revascularize, we can treat atrial fibrillation, place leads, congenital surgeries, and remove tumours. And one of the things I think was really key was that the instruments had to develop to go alongside this, and that was a really key point about development of minimally invasive. But we needed to make sure that this was equal to open access, to full access, but with some benefits. So what does it offer? And actually the benefits seem to be, decreased lengths of stay, intensive care stay, pain, quality of life. And they're all the things that matter to the patients. Cost, actually, there are studies that have proven that it reduces the cost. And the other thing is it's good for the surgeons. Robotics, if you go your way to robotics, is good for surgeons and posture and sitting. With this whole advent of minimally invasive surgery, did you predict this when you started?
We had started with trying to be minimally invasive back in clearly the early 80s. CTS designed a retractor, a disposable retractor to do, a mid-cab operation. We didn't know it was going to be an iterative process. Cardiology has driven a lot of this because while we were doing bypasses by the thousands, they were doing some innovative stuff. Now, they took some great risks to do some of this stuff. I remember when TAVR came, or you call it TAVI, came along, and Mike Mack and I were in Germany. We saw some early models of this thing, and people say it's not going to work. Mack and I looked at each other and said, it's going to work. But I think it's sort of like, we stand on the shoulders of giants. That basically, we've thrown the ball out into the cricket field, and both it's up to you to hit it now.
We can now do robotic mitrals. They're commonplace. It's a normal thing. But we're also, doing edge-to-edge repairs. Well, the cardiologists are. If you are someone who was researching this area, what would your focus be in terms of mitral replacement, repair?
First of all, I would start out with echo. As you are a surgeon, you need to be able a lot about echo, and we can still advance echo. We can put, metrics on everything and determine how the valve is going to be reconstructed. A lot of the research is going to be done by industry. And, it's not like the old days. You go to the lab and you've got, EKG and a dog, and, you do some study and find out how the heart's working. It's, it's all either genetic, macro, or micro, or macro. And so I think knowing what's evolved in cardiology, it sort of spurs on young surgeons to do something and prove it.
Exactly. And yet again, it's that working with the whole heart team actually progresses the whole specialty by motivating others.
But you're going to have to partner with industry. And What you do is you get at your university, you get your engineers and get them to work with these companies. Remember, these companies, they're not going to tell you things in the back room that they're working on. That's so proprietary. It's more proprietary than a secret airplane we're developing.
And that's that even expanding that team further. As we talked about the heart team, that's expanding it to the engineers. And, if you look back on the history of cardiac surgery or the history of medicine, so many inventions and advances were where doctors or surgeons worked with non-medical people to use their expertise. And I do think sometimes we have lost that a bit. It's more industry sort of come and say, use this, whereas I think that back and forth of information should really be the forefront.
They may know how to make it, but you're finding the need. You got to find the unmet need first. It's either better repair, shortening the operative times. Perhaps in the future, wouldn't it be neat to be able to go under blood in a beating heart and repair a valve? That's the same as the clip, but it's a better repair.
Yeah. For those first year residents or for medical students, just briefly, what are the key steps with minimally invasive or robotic mitral valve surgery?
I think you have to teach them the concept, where we were. I always say, go back to the original mitral valve repair that was ever done and work up the history of it. And then you'll understand it, that it is an iterative process. You want to have them in the operating room to see this. But to simplify it, you have to make simple diagrams and simple understanding of it, and then take them right up to, you take them through a protocol and teaching them.
And why hasn't the robotic bypass taken off? Is it logistics in terms of your vision? Is it being the on pump, off pump? Or is it the fact that actually, like we've been talking about, hybrid approaches are really taking off and are much more?
I think hybrid approaches are going to take off much, much more. We have gone almost logarithmically with LAD lesions and circ lesions or right lesions to going to a hybrid approach. Because, I believe in my heart, and a lot of people believe that that's a good operation. You're taking care of all the ischemic area. But to do, 3 or 4 bypasses robotically, you're going to have to make the heart smaller. Unless you got a robot that can come over to the other side.
Yeah.
It's really hard to do a full revascularization and sew it with the robot unless you're on the pump. And it's still hard.
And that brings me quite nicely onto sort of the final surgery I want to discuss, which is the aortic valve. Now, this is something that we don't use robots in very much at all. It's really only taken off recently. We've done minimally invasive in terms of hemistenotomies and mini stenotomies, but sort of robotic wise, it's not, there. We're beginning to develop things like sutureless valves, which can help with these minimally invasive. But, should we be developing that and pushing for that, or will the TAVI?
Vinay Badwar, who's at the University of West Virginia, is a really smart guy, and he took over sort of the aortic, where we had done the mitral. And so he's done a number, and people who've watched him operate say it's very slick. Follow Vinay's work because he's been very innovative. He's written a lot of papers on this stuff. I think you'll see a number of people doing aortics, and he's doing them from the side, just like we did. It's not here. He's doing them from the side and through a decision about like your mitral.
Do you think that we'll ever see things like root replacements, dissections done minimally invasively and robotically?
Well, I don't think they'll be done robotically. I think they'll be done with endovascular stuff. So I think the big stuff is going to be replaced by better and better endovascular stuff.
It's been an absolutely wonderful talk with you. It's just so amazing, your knowledge and what you've done, and how you're so still involved in the specialty and where it's going. But there is something that I do want to ask, which is you have many hobbies outside of medicine: photography, fishing, collecting old medical books, radio operator, optics, all this. And it's so nice to see, because cardiothoracic surgery can sometimes be seen as this, it's your whole life. And obviously we're aiming this for trainees. How do you balance it?
I tell doctors when they're young, I said, pick two hobbies, one inside and one outside,
Mm.
and learn them well.
Yeah.
Everything I've done as a hobby or another job has been additive to my knowledge.
Mm. If I can ask you one last question, is if you could go back to yourself as a medical student, what one bit of advice would you give yourself?
You can't decide totally what you want to be in medical school because you're going to take little bits and pieces of everything. But you've got to kind of, am I going to do interventional things? Am I going to be a gastroenterologist? Am I going to be a cardiologist? Am I going to be a surgeon? Am I going to be an electrophysiologist? Because that's totally different than someone who treats diabetes. I think cardiology and surgery is still very, very exciting. And once I was turned on to this one guy to do this, he would drag me to the operating room and tell the professor, Professor, I've got Chitwood here. He's a medical student. Show him something. And,
Mm-hmm.
You go watch some of this stuff and say, can I do this? Well, you find yourself many years later, you can do it. My mother watched me do an operation when she was in her 80s. She was a nurse. And so she looks over the screen and I'm putting a valve in. And she'd never seen a heart operation.
Wow.
And she leans back. We never thought he was going to finish high school. A team, But the point is, you can do this stuff.
Well, thank you so much for your time, Dr. Chitwood. It's been excellent. And I'm sure everyone's going to find this all so useful and so inspirational as well. For our listeners, stay tuned for next month's episode of the Atrium.